In this lecture, we'll focus on hypertension, a very commonly encountered cardiovascular disease in the clinic, and this is something we need to know a little bit about. First of all, what the actual definitions of hypertension are in terms of numbers, systolic, diastolic. What are the causes? Why are we concerned about it? What are the complications? How is it assessed? And then what are the treatment options? So hypertension or high blood pressure is a chronic condition in which the blood pressure is persistently elevated. We estimate that it affects about a third of the global population. And in the US, of those who have been diagnosed with high blood pressure, just over half actually have it controlled. So there's a lot of room for improvement here. It accounts for about, the estimates were in 2014, over 400,000 deaths in the US could be directly linked to the effects of hypertension. So this is again one of our so-called modifiable risk factors for cardiovascular disease. The thing about hypertension is that it typically is asymptomatic, especially in the early stages. But we have increased long-term risk from hypertension for heart disease. Specifically, it increases the risk of atherosclerotic cardiovascular disease, heart failure, as well as different heart arrhythmias like atrial fibrillation. There's an increased risk of eye disease. So with time, the high blood pressure and the changes that it causes in the arterioles leads to retinopathy and vision loss. It can damage the kidneys, resulting in chronic kidney disease, as well as dementia, and that's the changes in the central nervous system. So those are some of the complications as to why we're concerned about high blood pressure, and I'll go through that list in more detail in just a moment here. In terms of classification, the guidelines kind of shift every few years. Our current guidelines actually come from a couple of different guideline committees. So the Joint National Commission, they put out their 8th report in 2014, JNC 8. And then the American College of Cardiology, American Heart Association have guidelines from 2017. But basically, we consider a normal blood pressure to be anything under 120 over 80. So 120 systolic, 80 diastolic. An elevated blood pressure would be between 120 and 129 systolic and less than 80 diastolic. And then a stage 1 hypertension would be from 130 to 139 systolic or 80 to 89 diastolic. Stage 2 would be 140 or higher systolic, and diastolic 90 or higher. And then what we call a hypertensive crisis would be any time a person's blood pressure is either systolically over 180 or diastolically over 120. Now, in terms of these numbers, if you have a patient that came in with a blood pressure, for example, 135 over 78. So let's give that as an example, 135 over 78. By definition, we'd actually use the higher number. So this person would be classified actually as having stage 1 hypertension, even though their diastolic is in the normal range. So that's how we interpret those things. Now, a couple of comments here. Number one, we can't just take a single blood pressure reading and use that to diagnose hypertension. There needs to be at least 3 separate blood pressure readings, typically on 3 separate visits. And typically we're going to want to also measure blood pressure in both arms, especially on the first, sort of the initial assessment of hypertension. So just taking a single blood pressure reading, we know that people might be under a stressor. They might, the so-called white coat hypertension. They come to the doctor's office. They just had a couple of cups of coffee, things like that. So a single reading is not adequate to diagnose hypertension. We're also finding that what are called ambulatory blood pressures, and that's where a patient is sent home with a special device that actually randomly checks blood pressure throughout the day and then averages those values, is much more accurate than either the patient taking their blood pressure or the doctor taking the blood pressure. These devices are becoming smaller, more portable, and I think in the future we're going to see a lot more of this. And with all the new digital technology, we'll start to see that your pulse, your respiratory rate, your blood pressure, maybe your pulse ox, all those different things will be monitored potentially continuously, and then that'll give us some more accurate data. We can say that's a double-edged sword. That might give us too much data and cause too much intervention when we might not need that. But these are the basic definitions of the different blood pressure levels according to the different guideline committees. Now, there's different types of hypertension, so we usually divide it into what's called primary versus secondary hypertension. Primary is also known as essential hypertension, and that accounts for up to 95% of all hypertensive patients. And secondary would be, it's less common, 5% or less of all hypertension. Secondary, let me start with that one because this one is easier to understand. This is where high blood pressure results from a known secondary medical cause. And the most typical causes would be in the kidneys, so having kidney disease like nephritis, inflammation in the kidneys, or a polycystic kidney disease, as well as, and I'll jump down to vascular here, renal artery stenosis. So we already talked about that, and that's where the arteries that feed the kidneys, the renal arteries, develop atherosclerotic plaque, and that diminishes blood flow into the kidneys. So the kidneys perceive a decreased perfusion, and they're going to start churning out renin. So remember the whole renin, angiotensin, aldosterone system. If you don't, go back and review that. So when that's activated, that will raise blood pressure. This can actually be assessed through physical exam, listening for abdominal bruits. So that's the renal causes. There can be endocrine causes of high blood pressure. So a pheochromocytoma is a tumor of the adrenal medulla, or about 10% of them actually occur outside of the adrenal medulla in any of the sympathetic ganglia. And basically you release large amounts of epinephrine, adrenaline. So you get these adrenaline bursts and you get palpitations, tachycardia, tremor, headache. So that's typical of a pheochromocytoma. Cushing's is another potential endocrine cause. This is high cortisol, and that has some very characteristic features of round sort of face, truncal obesity, purple striae. Having high levels of aldosterone, both of these come from the adrenal cortex, whereas a pheochromocytoma is of the adrenal medulla. And this is called Conn syndrome with high aldosterone. And aldosterone specifically tells the kidneys to inhibit sodium excretion. It holds on to sodium, and that also causes water to be retained, and that increases blood volume, that increases blood pressure. And then hyperthyroidism. So for many of our patients who present with hypertension, we've done the 3 readings, we find they're hypertensive, we usually think through quickly on this list of secondary hypertension, do any of these apply to them? And this can be pretty quickly ruled out. So for example, with the renal disease, we can do a complete metabolic panel, and that'll test for our estimated glomerular filtration rate, as well as BUN and creatinine. And these are all markers of kidney function. So a complete metabolic panel, very common test, would check our kidney function. We can do a TSH test to check for hyperthyroidism, maybe measuring free T4, free T3. The others we don't typically go in, although in Cushing's there'll be very characteristic changes in electrolytes. Same with aldosteronism. We usually see an elevated sodium and a depressed potassium. And again, these would be on the CMP. So CMP will help us differentiate a lot of these. Taking different drugs like corticosteroids, some contraceptives, NSAIDs, aspirin. Aspirin's a problem on the kidney. So over time, aspirin will actually cause kidney damage because it constricts the little blood vessels going into the kidneys. And some NSAIDs will do this as well, chronic ibuprofen and so forth. Tylenol doesn't seem to have the same effect there on the kidneys, but it can affect the liver. So going through the patient's drug history to see if they're taking anything that might be raising their blood pressure. Vascular causes, I mentioned the renal artery stenosis, and then coarctation of the aorta. I talked about that in the previous video, but we can check the blood pressure in each arm there. And then pregnancy, hypertension of pregnancy, and then sleep disturbances like sleep apnea. So we can quickly go through that list and rule these things out to rule out any secondary causes of hypertension. But most patients with hypertension have primary hypertension, so we have no one cause. It's possibly usually multifactorial. And typically it's associated with increased ASCVD risk factors. So we went over those several videos back. So having metabolic syndrome, obesity, very common cause of hypertension. In fact, the definition of metabolic syndrome is you have to have hypertension as one of the criteria. Having endothelial dysfunction, systemic vascular inflammation, like we've talked about, with risks for atherosclerotic cardiovascular disease. Diet nutrient factors, so high sodium diets over 2,000 milligrams a day. And we suspect, especially in the context of high carb, high saturated fat diets, increased alcohol intake, and then having inadequate of the omega-3 oils, and then potentially vitamin D deficiency, although that's being questioned currently. Genetics, aging, these are again non-modifiable risk factors, but aging, genetic mutations, family history, all these can be associated with increased risk for high blood pressure. And then clinically, I find these are potentially modifiable factors, and this would be neuroendocrine imbalance, so activation of your sympathetic nervous system. People who are in chronic sympathetic stress. This is again where measures like personal care, mindfulness practices, meditation practices, the acupuncture therapies, nervine, herbs, all those kind of things can help downregulate the sympathetics. A increased activity of the renin-angiotensin-aldosterone system. So that would be another cause there. And that often goes along with chronic sympathetic stress will overactivate that system. Having cortisol hyperactivation, not to the point of Cushing's, but more just from chronic stressors. We think that might contribute to it. Insulin resistance, again, more not hyperthyroidism, but even hypo or subclinical thyroid problems, as well as sex hormone problems like low estrogen after menopause. I've seen many women's blood pressure shoot up at menopause due to loss of the estrogens, potentially progesterone, and that all causes blood pressure to go up. So these would be, looking at essentially pattern differentiation to try to understand those potential causes. So these are the two types of hypertension, primary and secondary. Now, why are we worried about hypertension? Again, the complications can include some very serious kind of end organ problems. So cardiovascular disease is a big one. So hypertension is the most important risk factor for cardiovascular morbidity and mortality. And chronic hypertension can result in heart failure, can result in an enlargement of the left ventricle. That often contributes to heart failure, the left ventricular hypertrophy. It can contribute to coronary artery disease and increase the risk for MIs, increase the risk of strokes, cerebral vascular accidents, increase the risk of peripheral artery disease. And what can happen over time with that increased pressure is that the arterioles become fibrotic. And we already discussed this. This can lead to arterial sclerosis. So chronic hypertension seems to precipitate arterial sclerosis. Now the question is, does arterial sclerosis precede hypertension, or is it vice versa? They seem to be kind of tightly interlinked. So effects on the cardiovascular system, that's one main set of complications of hypertension. The other would be damage to the retina, and that would cause hypertensive retinopathy, where the retina, this can actually over time destroy the retina, and that leads to blindness. And then the kidneys would be the other big system affected. So hypertensive nephropathy, and we can develop renal failure, and a specific type of renal failure that's known as benign nephrosclerosis. And this results essentially in protein being spilled in the urine, that's called proteinuria, and a decreased ability of the kidneys to filtrate. And that would result in a decreased estimated glomerular filtration rate, eGFR. So these would be some of the main effects. Now, with the cardiovascular disease, with decreased blood flow to the brain, of course, we have a lot of brain issues that can result from that. So think cardiovascular system, heart, blood vessels, retina, kidneys, brain. These are all affected by chronic hypertension. Now, we can develop something called a hypertensive crisis. This is also known as malignant hypertension. And this is a severely elevated blood pressure, and this is the red flag to kind of look out for with blood pressure. And that is where your systolic pressure is over 180 and diastolic is over 110. Some sources say 120. We usually use 110 to be more conservative. And we can classify this into two types. So hypertensive urgency, there is no evidence of end organ damage. So basically, there's no signs of kidney problems. The eye, we're not seeing any changes on the retina exam, called that fundoscopy. Here's actually an evidence of papilledema, but we can see all sorts of changes in the blood vessels of the retina in hypertensive, malignant hypertension. One of the things is we might see increased intracranial pressure, and that's the papilledema sign right here. Looks almost like from the optic nerve. This is where the optic nerve is centered. It kind of looks like a burst of sun rays coming out, and that's indicating increased pressure on the optic nerve, and generally from increased intracranial pressure. So that's hypertensive urgency. We're not seeing any evidence of end organ damage. Here, typically the treatment is to use oral medications to lower the blood pressure over 24 to 48 hours. So starting patients usually on 2, even 3 blood pressure medications to get their pressures down would be the typical approach with that. But we do have patients that present with those high blood pressures that have hypertensive emergency, and that's where we have evidence of end organ damage in 1 or more organs. And that could include the hyperintensive encephalopathy with confusion, drowsiness, seizures, retinal papilledema, fundal bleeds and exudates, like I just pointed out, chest pain, which may progress to an MI or even aortic dissection. We talked about that in the last video. Pulmonary edema with breathlessness, cough, and hemoptysis. And then acute kidney injury with proteinuria and hemolytic anemia, where your blood actually hemolyzes due to the increased pressure and turbulence in the blood. And this requires emergency rapid control, usually with intravenous agents, IV sodium nitroprusside, some of those others we talked about in the cardiovascular medication video. Here is, just on the right before I move on, here's actually a picture or a little drawing of this is the right ventricle, so this is a cross-section of the heart muscle. Here's the left ventricle, and this is the left ventricle that's undergone a left ventricular hypertrophy. So notice very thickened and so forth. This has to do with the fact that the afterload, the pressure in the arterial system is so increased that the left ventricle has to work harder to push the blood out of the heart. And as a result, the muscle enlarges, but over time, the Frank-Starling mechanism breaks down, the muscle is able to contract less efficiently, and ultimately leads to heart failure with decreased cardiac output and so forth. So we'll look at heart failure as a separate section, but this is one complication of chronic hypertension. Let me talk a little bit about hypertension in pregnancy. Hypertension occurs in about 8 to 10% of all pregnancies, and that is defined in pregnancy as a blood pressure over 140/90. And that can be classified as pre-existing hypertension. So a woman has had hypertension before her pregnancy, and this just continues into pregnancy. It can be classified as gestational hypertension, so it begins during pregnancy, or as preeclampsia, which is much more severe. Preeclampsia, this can lead to what's called eclampsia, which causes a hypertensive emergency. So it can be fatal. In fact, this accounts for about 16% of all maternal deaths globally, is preeclampsia developing into eclampsia. It occurs in about 5% of all pregnancies. What we see in preeclampsia is elevated blood pressure with protein being spilled into the urine, indicating renal damage. And it actually doubles the risk of the baby dying at delivery. The increased damage to the kidneys and the blood pressure eventually results in the hypertensive emergency. And so we're seeing end organ damage there. So that's not common, but definitely a concern in pregnancy, and this is always being monitored by the obstetrician or the midwives or whoever's working with that pregnant mother. Okay, so that's some of the important complications to know about related to hypertension. All right, here I want to say a few words about the biomedical assessment of hypertension. So in adjunctive care practices, acupuncture, whatnot, you may or may not be measuring patients' blood pressure. It's a good practice to do so, especially if these patients do not have a primary care provider. If you have 3 readings that indicate hypertension, then generally it's a good practice to refer out to to a primary care provider or someone that can manage that hypertension, at least to help classify it and determine the stage and work further on that. So biomedically, the kind of steps that are used for hypertension would be, again, first to classify the hypertension. So we'd look at, do we think it's essential or primary hypertension, or is there a secondary cause that can be identified? And that usually is going to be doing some basic blood tests to see if anything can be picked up there. And then we'll determine the stage. So based on the numbers that I pointed out earlier, we'll classify a patient as either, if they're hypertensive, stage 1, stage 2, or, hopefully not, the malignant hypertension. And then we look at all the risk factors and comorbidities. So again, evaluating for all those cardiovascular risk factors we've talked about in the past through their history and maybe through physical exam, and then reveal any identifiable causes of their hypertension. So this would all be part of our history assessment and our kind of initial thinking behind that. Again, the risk factors for cardiovascular disease, hypertension is one of them, but obesity, that's a BMI of over 30. And dyslipidemias, so we've talked all about cholesterol earlier, elevated LDL, low HDL, potentially high triglycerides would be all risk factors. Having diabetes, both type 1 and type 2, although type 2 seems to have more of the cardiometabolic risk. Cigarette smoking, physical inactivity, any presence of renal disease, so any signs that the kidneys are spilling protein into the urine. Typically, the way we assess that, I'll just say here briefly, is in the clinic we have the dipsticks, which we put into the urine, and there's a lot of different indicators on that stick which can tell different things. Like one of the indicators looks for the amount of protein in the urine. However, that can only measure protein over a certain limit, and so we're interested actually before that occurs in what is called microalbuminuria. And that requires a specialized test. So we need to actually order a special urine test that's done in the lab to assess for that. But that can detect the presence of very small amounts of albumin in the urine, which can indicate renal disease. Increased age, so over 55 for men, over 65 for females. And then a family history of premature cardiovascular disease. And we already talked about that. That's where if your father had an MI or a cardiovascular event before 55 and your mother before 65. So if a patient has any of these in their history, these would all be increased risk factors. And again, we might want to use the ASCVD risk calculation, the 10-year risk score that we talked about earlier, is an additional assessment tool here to see how aggressive do we need to be with treatment on these different factors. So basically, after we've classified, looked at the risk factors, we might think about doing a referral. Again, a patient should have a primary care provider. If you're not a primary care provider, that should be referred to one. And for secondary hypertension, typically we get the advice of cardiologists and endocrinologists on how to proceed there. If there is a hypertensive crisis, especially with end organ signs, then you should call 911. That person needs to be immediately, given intravenous vasodilators and so forth to get the blood pressure down. If you have a patient that is that's in hypertensive crisis, so their systolic is over 180, their diastolic is over 110, they're not showing any evidence of end organ damage. Again, that's a hypertensive urgency, not emergency. That person, if you are a primary care provider, that can be started on the medications, again, monitored over the next 24 to 48 hours. But if you are not a PCP, they need to be referred. And most typically, to do that quickly, they're going to need to go to urgent care. Usually they can deal with that. And again, if there's any end organ damage, they'll need to go to the emergency room. So that is the referrals. And then, again, we need in the office to do the blood pressure readings separately. Usually what we do typically in our first visit is get 2 readings at least 5 minutes apart, again bilaterally, and then we get 3 separate readings at least 1 day apart to kind of confirm that the blood pressure is elevated. I have some patients who come for the initial visit, it's elevated, and I just ask them to come back in a couple of days, and just any provider in the clinic, if you work in a multi disciplinary clinic with a lot of different providers can usually do that. A lot of clinics will have an MA or someone that can just take the blood pressure. If the first reading is in stage 2, we usually repeat the test within 1 week to get that second blood pressure reading. Otherwise, we can wait up to 2 months to get, if there's stage 1 or elevated blood pressure, we can wait a little while to get that. But we should get 3 readings to confirm the high blood pressure. The exams that typically are done at the first visit in a kind of primary care setting would be the fundoscopic exam. Look at the retina, heart and lung exam, abdominal exam, and then peripheral vascular exams looking for any peripheral vascular disease. Most of these will be generally unremarkable unless it's more advanced. Labs for initial screening would include a CBC, a CMP, which would check for the renal function and electrolytes, as well as fasting glucose. The lipid panel, doing the microscopic urinalysis, that's called the urine albumin creatinine ratio. It goes by different names with different labs, but that is the name of the test. Again, that cannot be done with the dipstick. That's a specialized test. Checking thyroid function with TSH, calculating the BMI, and then if a patient has stage 2 blood pressure readings, we get an EKG, and then maybe a chest x-ray to look for any evidence of left ventricular hypertrophy. That will sometimes show up on the EKG as well. Remember, that's one of the 5 measures we can detect from EKG is ventricular hypertrophy. So those would be the kind of labs and screenings. We calculate our 10-year ASCVD risk if the patient has had no prior cardiovascular disease, and then we would monitor at each visit their vital signs and then do maybe specialized heart, lung, peripheral vascular exams if needed. So that's the typical kind of biomedical approach to hypertension, kind of how we screen people, and then what we do when we start to see elevated blood pressure readings. So now I want to say a few words about the biomedical treatment of hypertension. Again, these come from the different guidelines. I'm going to be using here the American Heart Association, American College of Cardiology 2017 guidelines. Again, a normal blood pressure is less than 120/80. And basically on our therapeutic order, we can use our level 1 therapies. So basically just keep the person healthy. Make sure we emphasize good, healthy diet, lifestyle, exercise, stress reduction. So that's level 1 therapies, or just keep doing what you're doing. Your blood pressure is normal. Elevated blood pressure would be 120 to 129 and less than 80 diastolic. Here we go to level 1 therapies. I usually add in level 2 therapies and then reassess in 3 to 6 months. So again, level 1 therapies, diet, exercise, lifestyle, stress reduction. Level 2 therapies would be doing maybe herbal therapies, micronutrients, acupuncture, and whatnot to help with that. So here we're trying to support salutogenesis and maybe do any hormone replacement therapy if necessary. So really working with the neuroendocrine system, working with the stress response, HPA axis, thyroid, pancreas, insulin, adrenal glands with the DHEA, and then sex hormones. In Chinese medicine, this would be identifying any potential patterns. For example, a liver fire yang rising pattern, liver qi constriction, phlegm dampness, kidney yin deficiency, kidney yang deficiency, and blood stasis. Those would all be patterns that might show up there. So, and those could be addressed appropriately with lifestyle, with herbal medicine, and with acupuncture. So that would be level 2 and level 3 therapies there. With stage 1 hypertension, and that's again a systolic up to 1, so between 130 and 139, and diastolic 80 to 89. If the person's 10-year ASCVD risk is less than 10%, then we can essentially focus again on just level 1, level 2 therapies and reassess in a few months and see where the blood pressures are at. If their 10-year ASCVD risk is over 10%, then we're going to go and really emphasize level 4 and then backtrack and do level 1s and level 2. But this is going to need level 4 therapies, and that is going to essentially usually be medication therapy. So I'll review those here in just a minute. And then reassess in 1 month to see that the blood pressures have come down. If a patient is in stage 2 hypertension, then it's going to be, and that's again over 140, over 90, we're going to really emphasize stage 4 first and then backtrack on the other stages. So stage 4, essentially addressing pathogenesis, we're going to use our most common agents here, and I'll review them all in just a second, would be our ACE inhibitors, our angiotensin receptor blockers, our calcium channel blockers, and our thiazide diuretics. So that's going to be the typical first-line agents. Now, the guideline committees say that for different age groups, and even based on race, based on genetics, we should think about different combinations of these. So typically for Caucasian patients under 65 that need the medication, we usually start with an ACE inhibitor or an ARB. Would be the most common kind of recommendations there. For patients over 65 Caucasian or for black patients, that's when calcium channel blockers or thiazide diuretics work better. Remember, calcium channel blockers really are blocking vasoconstriction versus the ACE inhibitors, ARBs, are blocking the renin-angiotensin-aldosterone system. So in those cases, we're finding there's differences in different populations as to who needs which medication. So that's the typical recommendations. I mentioned one of the problems with the thiazides is that it seems to increase the risk of diabetes in some patients. So there's a little less emphasis now on the thiazides, although they are very cheap, very effective at bringing blood pressure down for a lot of people. And for more short-term use, like if we're working on level 1, level 2 therapies over time, they might be able to get off their blood pressure medications and in the future, and so we're not going to have them on it for long. So a thiazide is a good treatment there. Couple of notes, I mentioned this in the drug discussion lectures. Never combine an ACE inhibitor with an ARB. Again, if you're not prescribing these, that doesn't apply, but you might want to look at the patient's list of medications and see if that might be occurring. Let's see. And then you can use in combination. That would be first-line agents. We can use, for example, an ACE or an ARB with a thiazide or with the calcium channel blocker. So we start adding on after that month of initial assessment. If the blood pressure still hasn't gone down with a single agent in stage 2 hypertension, we might add on a second agent. So that's the typical thinking process that's used there. Second line agents would be beta blockers. Remember, they block the sympathetic nervous system, and alpha blockers. But these have actually not shown that they reduce cardiovascular risk or morbidity or mortality. So they're not considered primary agents, but they might be helpful for getting pressures down if the other agents are failing. Now, there is something called resistant hypertension, and that is hypertension that remains above the target in spite of 3 or more antihypertension drugs. And that's a real problem. Again, those are patients where from an adjunctive care setting, we can really focus on level 1, but especially level 2 therapies. Why we think this happens is that if the hypertension has been very long-standing, remember that the vasculature will undergo remodeling, and you'll start depositing connective tissue and whatnot in the arterial walls, making them stiff. And we don't know of anything that can reverse that if it's been going on for many years. And so that I have some patients who just don't respond to anything, and we suspect that's what's actually occurring. Now, I try to work a lot with them with level 2 therapies to protect endothelium and work with all that, but even with that, that's not always effective. Backing up here, I should say our BP targets for most patients with stage 2 hypertension really is not to get them down to normal necessarily. It's to get them below to get them under 140/90. And that's with especially if their ASCVD risk is over 10. If their ASCVD risk is over 10%, I'm sorry, I just said, so for most patients with ASCVD risk under 10%, we're going to look at the 140/90. If their ASCVD risk is over 10%, or if they're type 2 diabetic, or they have chronic kidney disease, the blood pressure target is 130/80, so under 130/80. So those are just some targets to keep in mind. Again, if you're not primarily managing hypertension and whatnot, you don't need to know all these details, but I think it's good to know what the general approach is, what the common medications are, and so forth. And if you forget these medications, I'd go back and review the pharmacology section. I went into those in depth, so I'm not going to repeat that here. Finally, for a hypertensive crisis, that's going to be a systolic over 180 or diastolic over 120. For primary care physicians, This would not be true for acupuncture or adjunctive care. You should refer all those cases out urgently. But for primary care physicians, if it's a hypertensive emergency, that can be managed in office. Again, patients have to be asymptomatic, no signs of end-stage organ damage, normal fundoscopic exam, no hematuria or microalbuminuria, normal CBC, BUN, creatinine electrolytes, and a normal EKG. So we check all those off the list, and then we monitor over the 48-hour period, usually with 2 or 3 medications on board to see if we can get blood pressure down. With the hypertensive emergency, though, that is a medical emergency that needs usually intravenous agents, and they need to be in the ER or hospitalized to address that. Okay, so that's an overview of the biomedical approach to hypertension. Again, very, very commonly encountered, and it is important if you're not in primary care to, at least with your patients, to do initial blood pressure screenings, and if they fall into the elevated categories, to refer those cases out so that they can get be properly managed that way. Now, I'll just say a little word about acupuncture. There's several studies that have looked at acupuncture and blood pressure lowering. It's effective, and so we do see results. Unfortunately, the studies that were done in China primarily, and the patients were going, like it's typical in China, to get acupuncture 3 or 4 times a week for 3 to 6 months. That is just not practical in the United States. And unfortunately, several of those studies showed that the blood pressures were reduced while the patients were receiving acupuncture, but then 3 months after they discontinued therapy, the blood pressures went right back up to where they had been previously. And so this is unfortunately an issue. We can argue there's maybe different acupuncture styles and techniques which are better than another. Maybe if you combine it with herbal therapies, that would help. But this can be an issue for patients, especially for patients paying out of pocket whose insurance doesn't cover it. Thiazide diuretic costs, 3 to 5 cents a day, if even that, versus, an acupuncture treatment, which might lower the blood pressure in the same way, by the same amount, is going to be a lot more expensive and have to be done a lot more frequently. So unfortunately, I sometimes find myself making these kind of decisions in the clinic with patients when I feel like I think they would benefit from acupuncture, and it'd be really nice if everyone could get that every day, but it's just not always practical, and that's where the medications here can come in and be useful. Now, we can argue that the benefits of acupuncture go far beyond what the medications can give, and taking the sympathetic stress off the heart and whatnot, so they have other benefits. But in terms of just focusing on blood pressure, it often is frustrating for patients to see their pressures are not coming down and so forth. And I've also seen in acupuncture practices people not monitor the blood pressure. I saw one patient had been treated for a year in acupuncture, didn't have a primary care physician, came to see me as a PCP, and her pressures had been really elevated, probably for a long time. And she was in high stage 2. She was almost in the hypertensive emergency stage. And no one had ever checked that. And so that's something where we definitely, she's at much higher risk for stroke and all these other complications. And so that's something we need to be looking out for. Okay, so that's an overview of the biomedical approach to treatment for hypertension. Here is from the ACC-AHA, just a little algorithm for, again, what I just presented on the previous slide in a more graphical format, but you can look through it. But basically this kind of, again, looking at the normal blood pressure versus elevated versus stage 1, stage 2, what our approaches are in terms of should they be on medication, can we just use diet, lifestyle, whatnot to manage them appropriately, and so forth. It is a thing now in medicine where we do have all these different guidelines, and more and more providers, especially if a person calls themselves a primary care physician, really needs to adhere to these guidelines, because if there is a situation where a patient has an adverse event or something, if the provider didn't really follow the guidelines, they can be held liable for not appropriately addressing that. So more and more, we're unfortunately seeing more restriction in healthcare. The idea is it's improving outcomes, hopefully, and improving patient care, but it does, put limits on terms of how much flexibility we have sometimes using other treatments. But the way I approach that is, again, through the therapeutic order, knowing, number one, which stage do we need to start at? If we start at level 4, great, but then we can always backtrack to level 1, level 2, etc., and work that way. So we shouldn't abandon, our adjunctive integrative therapies when a person is on the medication. In fact, that's when I think I look at the medication as sort of a temporary measure, hopefully, while we get the system kind of reestablished and we can work that way. Okay, so that's it for hypertension. Again, be familiar with the major medications that are used, those classes of medications, and understand the general classes of hypertension, the difference between primary and secondary hypertension, the complications that can result from hypertension, how it's assessed, and then what the kind of biomedical approach is together with the therapeutic order, how we can think about that clinically.